Okay, well, we turn now to the IPQR and ask David to lead us through the IPQR with Lorraine. Thanks.
Thanks, Boyd, and good afternoon, everyone. You'll have a copy of the January IPQR. You'll see that the format has significantly changed since the last version, and hopefully you'll find that of benefit. A reminder that the data that's contained in here goes to the subcommittees of the board that are tasked to look at the various elements of it, and this is a compilation of some of the data that's reviewed within these subcommittees. You'll see that the report is themed across 5 different areas as outlined on the front page of the report. You'll be somewhat familiar with them and become more familiar with those as time goes on, because they are the backdrop to which our 3 to 5 year strategy will be developed around. And I think it's useful to see the performance in relation to those. You'll see that again that there are executive leads for the various sections who will be able to answer questions in a moment relating to that. And just in terms of context, you'll see that it follows a similar pattern. This is a pattern that we hope to roll out to the reports that will go into the subcommittees, and we will share that with each of them. Within it, you'll see that not only is our performance measured and reported on, but also it's benchmarked across, in many cases, what we've described as similar boards to ourselves, so that you can see that as well, in some cases, to what the national standards and the national performance is. You'll also see that some general comments by the executive leads, as well as risk and mitigations of some of the aspects of the data that is being reported to. So just wanted to say at the beginning, thanks to Lorraine Cowie and the team who have been working hard along with the chairs and exec leads to get this report into this format, and hopefully colleagues will find this of benefit. Given the time, I'm not going to go through any in detail, but I'm happy to open up to questions, whether that be related to, I would suggest maybe the formatting of it. If there's comments related to that, happy to take them offline rather than do that in the board time today, but always welcome so that we can make further refinements. So if I can just open up perhaps to questions, that would be fine.
Well, if you're getting a bit of feedback, David, as well, I think there must be somebody not muted.
Anne?
Thanks, David, and certainly it's a very colourful report now, but lots of useful additions, specifically, for example, those benchmarking information that you've provided. So well done on all of that. Just a couple of couple of questions from me. Firstly, for Catherine, I suspect. So it's great to see the impact that the Highland Urology Centre has made on our performance as regards waiting times. And I just wondered, Catherine, there's obviously a long list of potential improvements in the remobilisation plan that's also on the agenda today that could improve our performance. I wondered if you could single out for us maybe a couple of developments that you think are critical to make the kind of impact that the Urology Centre has made across our performance. So that was one question. And the other thing that really struck me by having the remobilisation plan on the agenda as well as the IPQR was the extent to which issues around e-health and technology underpin a very wide range of our activities. And obviously, I appreciate, Lorraine, that this is a work, and David, this is a work in progress. It always has been, and it will continue to be. And I just wondered what, if any, thoughts you have at the moment about being able to, I'm not even sure what performance would represent in terms of technology, but I just feel it comes across as such a key to our future and achieving improved performance and access to services that it's important. It would be important to somehow see it represented in the IPQR. Don't know what your thoughts are on that. Thanks.
Thanks, Anne. I'll maybe take your second question first and then hand over to Catherine. I think it's absolutely the case that technology has played a key part in a lot of the development of services. And in many cases, you will see the theme of technology being adopted in a number of our services. And that's really where the performance is best reported, I would suggest, because at the end of the day, technology is not there for technology's sake, but actually for the benefit and the delivery to patients. However, we are developing our digital health and care strategy, and there is a session, I think it's tomorrow actually, with a formal session later where we are engaged directly with our clinicians to ensure that the direction of travel that we had previously set is still the same direction of travel with the right priorities in terms of where we want to go now, because I think we've had a lot of learning over this period of time, and we need to be able to make sure that our strategy adopts and adapts to the different challenges and opportunities that we now have, where also I think some of the barriers that we previously had put in place to development have softened, recognised we've had to do it in many cases. So now we've got some very good and valid choices to make in terms of going forward. That strategy certainly goes through and shared with the Finance and Performance Subcommittee, but I'm more than happy to look at how we can pull something together for the benefit of the board in the way that you've described. Catherine, did you want to pick up the question around cancer services?
Yeah, thanks. And thanks for the question, Anne. It's a good question, and I'm struggling to fit it into 3. So I hope you're going to allow me to have 5 responses to that. The first one is diagnostic. So in all of our patient pathways, if we can actually get to a diagnosis, the sooner we can do that, we can sort of weed out the wheat from the chaff, for want of a better way of describing it, so that we can actually then identify the patients that really need to access service. So that's one key point that we need to make, and that needs to be done across all service areas. The other one is workforce and capacity for workforce to deliver. And then within the cancer services in particular, the team came together around that, and they were determined that they were not going to accept delay for these patients. And so they reprioritised within the existing resource and really drove that improvement themselves. So there's something in there around not accepting delay and putting the patient at the centre of the teamwork that was going on. And that, the team really do need to be commended in terms of that. And then the final one around the recovery, I would say, is our pathways around flow and allowing us to put in place services that are not interrupted due to various impacts. And we know we've had the impact of the pandemic, but we are quite often faced with cancellation due to bed availability. So how do we actually design a system that doesn't allow that to happen, so that we can deliver robustly every day, and we can actually learn and fine-tune our processes? It's very difficult if we have those cancellations and continued interruptions. So I appreciate it was more than 2 things, Anne, but I hope that's helpful in terms of giving you some context.
Thanks, Catherine. There's a number of folk looking for questions and comments. I'll take two at a time maybe. So Jerry, then Philip.
Thank you, David. Let me just start off by saying how much I enjoyed the new format. I know although it looks very summarised, there actually is an incredible amount of information in there. Actually, once you start delving into it, and I enjoyed the comparative stuff. So, and I also take a lot of assurance from the work of the committees in terms of when they delve really into the details. So I think we're really beginning to get the balance presented to the board in terms of what we need. So I suppose my question links in many ways to what Catherine has just been speaking about. If you look at diagnostic scopes, undoubtedly the number on the lists themselves is increasing quite markedly, but we now appear to be up to about 50% of that list waiting more than 6 weeks. And I suppose it links into that cancer improvement plan as well. The first step to the cancer is the diagnostics, and it was really just to get an idea of what improvement work we've got underway or are planning in terms of the diagnostic scopes, and how we can start to bring that back down to a more acceptable number moving forward. Thank you, David.
Thanks, Jenny. We'll come to that in a moment. Philip?
Yeah, thanks so much, David. And I know you weren't wanting to comment too much on the presentation, but I think it's a huge improvement. I just can't begin without saying that. In terms of my question, I noticed on the people dashboard there was a figure of 8.9% of our absences in 20 to 21 were mental health absences. I'm not clear if that is a national figure or if that's the local figure. And in any case, how does our local absence relate to the national absence? And I'm very aware of all the work we're doing with well-being and culture. Are there any specific actions to deal with that high number there? Because I think that'll fall across into some of the community planning work we're doing, which sees mental health as a huge issue.
Thanks, Philip. The line was breaking up a little bit there, but I think I got most of that, and hopefully Fiona will when I come to her in a moment. Catherine, do you want to make a comment around diagnostics? And then I'll come to Fiona.
Yeah, sure, David. So the part of the reason for that increase is because we had started to deliver some increase around outpatient work that we had agreed to do with a view to recovering the outpatient side, and there was therefore a conversion of a certain number of those patients that required diagnostics. But also we have lost some capacity due to the Omicron breakout, so we'd had to step down some of our capacity due to the availability of our nursing workforce. So our plan to recover that really is to attempt to increase our diagnostic capacity. We believe we've got enough because, as you'll know, Jerry, we built a fourth room, we've staffed the fourth room, so now we need to ensure that that capacity is maxed out and we're delivering every day to that. We believe that will allow us to contain the requirements from the diagnostic end. Thanks.
Thanks, Catherine. Fiona, can I come to you?
Yeah, apologies, my mouse got stuck and I couldn't get myself off mute. So with regard to the 8.9% figure, I'm just reminding myself of that. I think in September in the IPQR, we did a bit of a look back on annual mental health related absence locally. So that figure is an NHS Highland figure, and I think it's a figure for the overall previous financial year from 2020 to 21. So we do look at it. I think one of our challenges in specifically reporting mental health absence is I suppose a combination of data and making sure that we have to go through that and categorise by absence types. We know there's also probably a significant amount of underreporting there because often, particularly around short-term mental health absences, people will often report with other symptoms, because they don't want to disclose that. I think when we previously looked, our position relative to other boards is kind of relatively consistent. I think one of the things, I mean, mental health and well-being is a huge part of our culture strategy. Obviously, we've received investment in this financial year from Scottish Government, like other boards. And we've you'll hear in the culture update later that our well-being, our health and well-being group has just relaunched, and we're aiming to have our well-being strategy agreed by the end of this financial year. The other things that we've been doing, we've now got since December our occupational health team, which already has 2 psychological therapy practitioners, does now also have a part-time dedicated clinical psychologist working alongside that. So they are seeing colleagues who are referred to them, but also they are working alongside us on our mental health and wellbeing strategy to make sure that actually that focus on prevention and proactive support locally. And one of the things we'll definitely be looking to expand in our strategy is around mental health first aid and awareness of mental health issues at work. So definitely a key challenge. You'll see on the overall absence that whilst we are seeing an increase in absence, which does tend to be typical at this time of year, we are continuing to track a few points below the Scottish average as well, but it's still a big area for us.
Thanks, Fiona. If I can come to Alex and then Brian.
Thanks, David. Yeah, I really like the format. I think it's good. It gives us the information clearly. And the good thing is, looking at it in the round, we're improving, which is another good thing. But the 2 bits I'm going to ask questions on, unfortunately, we're not improving. The first one for Catherine is the 62-day cancer treatment target or number. It's continually, it was improving. It's now starting to drop, and it's dropped for the last, I think it's 3 months, three periods. Do we know why, and what are we doing to try to get it to come back up again? And the other one is for Lorraine, and it's my usual pick on the delayed discharges, which keep going up, unfortunately. I don't seem to be doing.
Thanks, Alex. I'll come to Louise on that in a moment with regard to delayed discharges. Brian?
Yeah, thanks. Same as everybody else with regard to presentations. So much information is fabulous. Just a couple of quick questions, probably to Fiona, I think, with regard to the staff absence. One was, I'm assuming, and I think you just mentioned that there's some degree of seasonality in staff absence rates. So I was just wondering if you had a sense of how this last 12 months compared to the previous, particularly that rise in the autumn, whether that's higher than last autumn or lower. And then the second quick question was that I noticed there is this increase in staff turnover. I just wondered if we had any sense as to whether that was related to particularly an increase in the prevalence of long-term absence, then leading to people leaving the service. So whether there was a link there or not. So it's just those 2 quick questions. Thanks. Thanks,
Brian. Catherine, can I come to you first on the 62-day performance?
Yeah, sure. Alex, thanks for the question. So just to clarify in terms of the report, and I think that, we're all getting used to this new presentation, but on the 62-day target, it has been improving. The circles around the bottom show that we, 85.1%, 79.1%, and then 87.1% in October. The numbers in the boxes is the number of patients that we've processed through that have resulted in a positive cancer at the end of the day. So the numbers in the cancer performance report are slightly tricky in terms of understanding them. So we are continuing to improve. There is, however, you'll note on there that at the end of December there was a drop, and that's the position that's reported at the end of December. And we understand that was due to the availability of administrative staff, believe it or not, and also the availability of some capacity at other sites across Scotland that we rely on to access for some very specialist services to support those cancer pathways. So Alex, we continue to work with our partners in other health board areas, and we continue to work in this space. I hope that helps respond to that question.
Thanks, Catherine. And Louise, can I come to you around delayed discharges?
Yeah, absolutely. And clearly the detail speaks for itself there in terms of the slides. And the challenge that we've got is somewhat related, though not wholly related, to the follow-up slide that shows the reduction in ability to move people into care homes and the current waiting times for care at home. So you can see the correlation between the two in quite a significant way right now. However, that isn't the only story. This is very much about how we forward plan those discharges with people and understand where they need to be going and what else that we can do to move them into the community and have them in the right place. So we do have people within our acute hospitals, our community hospitals, and in our mental health facilities that are within these numbers. And you will see there have been some significant drops in the last year. And again, that's often where we've done some really focused, dedicated work to try and make a difference in some way, but we've not managed to sustain it. So the bit we've got to really get right is how we make the improvements and keep it there. So that's the challenge for us at the moment. We've now got a dedicated unscheduled care programme director who's working on this full time. And we are looking at doing some fundamentally different things, one being that we're setting up a discharge hub, which will be an amalgamation of social care, community and acute colleagues, very much working at how we pull people out of the hospital and have them in the right place, utilise things like interim care beds, etc. Mindful that the last few weeks has been tricky because the vast majority of our care home beds have been closed. And so we do need to look at how we build up the care home capacity, the care at home capacity, and also different models to keep people at home with that enhanced sort of community offer, the integrated teams, etc. So it's a whole picture, but we've got to just have a dedicated focus to get that consistent reduction rather than the peaks and troughs that we've seen over the last year.
Thanks, Louise. Maybe just to add, sometimes particularly around delayed discharges, it looks like it's a static number. I can assure you it's not a static number, and that there are patients who are being discharged and being able to put to the best appropriate place of care. The challenge in such a difficult environment, as we've seen in the charts that are affected by our social work capacity and our social care capacity, not necessarily all within NHS Highland, but also with our partners, has certainly been a challenge in that regard in recent weeks. But the programmes that we are putting in place, we expect to be able to deliver improvement. And as the attendance rate and the absence rate within the care sector starts to increase, then we hope to see an improvement in these numbers in the coming months. Fiona, if I can come to you with relation to the question about absence and trend.
Yeah, absolutely. So I've just had a look back to see in terms of the position in November 2020, both our figure locally and the national figures were tracking quite considerably lower, which is a trend we've seen. So we're sitting at 5.7% in November, and last year it was 4.8%. Nationally, they're sitting at 6.4%, and the year before they were sitting at 5.7%. There are a number of factors around that increasing trend. I think one of the things that we found through the kind of prior periods has been that a lot of the seasonal cold and flu related absences wasn't being reported as sickness absence before we had lots of testing available, because people were self-isolating, and that isn't included in our figures. There's definitely a bit of a kind of impact when we had a lot of people working remotely as well. Again, some people who, while we encourage people, if they're not well and not able to work, not to work, some things that you maybe wouldn't be able to come into the workplace. If you're working remotely, then you're able to continue to work. But there definitely is a kind of increase in the level of absence, and I think it's related, probably to the long-standing pressure on people as well. We do have an ageing workforce, and that long-term pressure and the pressure on our services over these times, I think, is definitely a factor. So it's something that we're very conscious of. I think from a turnover perspective, again, we're definitely seeing an increasing trend. The increasing trend, again, is slightly driven by the fact that for a period of time in the previous year, well, 2 years nearly, we didn't see a huge amount of movement. So you would normally see a kind of amount of turnover, and actually with lockdown and people not being quite sure what was happening, we actually saw quite a significant reduction over that period of time in turnover. So we are coming back more now to previous normal levels. There's another sort of factor there in that, again, we have our kind of ageing workforce. We know a lot of people are approaching kind of 55 and beyond, where they can start to think about taking pension, and the impact of the pandemic on people, both at work, but also actually their own personal preferences and what people feel willing to do and able to do has changed. So that definitely is seeing a bit of an uptick. So we're very conscious on seeing what we can do to help improve the turnover rates, recognising that turnover can be healthy and is healthy to a certain extent, but actually, for example, if some people are maybe leaving us slightly prematurely, and we're working on what options we can offer for people to come back on a part-time basis or to do roles that maybe aren't quite as physically or mentally challenging. So it's definitely an important area for us.
Thanks, Fiona. If I can come to Susan, Alistair, and then Bert.
Thank you, David, and just really want to say how engaging I found the whole report, and it really drew you in to be interested in reading it. So thank you for that. It's a really, really impressive piece of work. My question is more about, I'd be interested to know how widely this is distributed or could be distributed, because I think it could be a really important way of engaging our wider staff in our strategy and getting them involved in what we're doing. So is it, even if it's not immediately, but up to date, but is there some way of using this report as an engagement tool with our staff? Thank you.
Yeah, I think that's a really helpful idea, Susan. And if the data certainly is available to many staff, but not necessarily all staff avail themselves of it. But I think that's really helpful. Happy to take that away and consider how best we do that. Thank you. Alistair?
Yes, thank you, David. And yeah, I agree. It's an excellent report. Just on the cancer ones, I think the urology is a phenomenal success. I don't know if we're able to get an update as to where we are with adding on the robotic assisted operations to the urology to cut out the need for patients to go through to Aberdeen. So, maybe that's something that perhaps someone could answer. And I just wonder, on the way we're showing the stats, David, that you've got the numbers and the percentage underneath. I wonder if it would actually look better if it was the percentage stuff, because the numbers actually, don't actually, they are just numbers of people who've gone through, whereas the percentage underneath the graph for cancer is what we should be training the eye to. And I suppose the question to Catherine would be the 69.2%, apologies, I have bad connectivity if you answered this in your introduction, Catherine, the 69.2% performance in December, is a downturn. Is that due to seasonal holidays and things like that? What is the time lag? I noticed these graphs got to October. What is the normal time lag before we could get the information, for November, December coming through? On the waiting ones, no patient will wait longer than 12 weeks for the first outpatient appointment. I noticed ENT and dermatology are the highest. Is there a reason why they're the highest? Is it because we've got a lack of staff in that area, or would that be the same for any health board? Should we be aware or concerned, probably more question for Boyd Peters, should we be more aware or concerned of the ageing of the people on a waiting list? The only waiting list I'm familiar with is a council house waiting list. So forgive me if what I'm saying is different, but the ageing of that, is there some people that will be on a waiting list for a long time? And it's a question of how important is their position on the waiting list. I don't know if I'm making sense, but some waiting between the urgency of the waiting list, the people that are on it, and should that be a concern to us if somebody's on there for a length of time. And the final one on delayed discharges, it might be useful for us to know as to how much money is tied up with delayed discharges in terms of bed days, so we could get a sense as to how much would be freed up for acute if we actually weren't having a bed occupied by somebody that was heading for adult social care back to their own house, or patient, or waiting for a care package. You know, some sort of link between the monetary value tied up with a delayed discharge. I think that's everything. Thank you.
Thanks, Alistair. I'm going to try and keep hold of all those questions. Come to Bert, and then we'll try and circle and try to answer them.
Thanks very much, David. I think this might be a question for Boyd Peters. I've been looking at the graphs in relation to serious adverse events, but I've read that in conjunction with the minutes of the Audit Committee, which is further on in the agenda. And whilst the chart tells us that there's fluctuations in the numbers of the serious and adverse events over the given period that's shown in the graph, the minutes of the Audit Committee highlights, I think, certain areas which the committee have asked the clinical governance to spend some time looking at in its March meeting. And one of the things that I took out of that was the number of open investigations, which I think is 32 out of 45 reports being overdue, with some of them being overdue by, I think it said 2 years, which on the face of it seems to me to be quite an extraordinary length of time for an investigation. And I appreciate all of the factors that come into that, and these things don't, you know, they cannot be completed very quickly. But a couple of things come out of that for me, which is in relation to the learning. So how do we identify the learning at a point which is appropriate to prevent any potential recurrence, and not wait until the review is completed? And are these events ones which potentially need the duty of candour process to kick in? I think that's it all. Thank you.
Thanks, Bert. Maybe if I can come to Boyd first. Boyd, would you be able to pick that one up along with the question around the waiting lists and prioritisation and clinical prioritisation, as perhaps even the robotic urology question?
Yeah, sorry, I got disconnected for the second part of what Bert said. I got the SAR, the start of that. There's a lot in all of these. There's a lot of detail. The first thing I would say is that this is a new format, IPQR. That format is going to be very helpful for all of us. And to answer Susan's question, actually, we have already been feeding the IPQR down into the organisation. So that has been going on from its inception. The difference now is that what we've got is a document that is much more attractive and interesting to draw the reader in, and that's the effect. And of course, this represents barely the tip of an iceberg of data that's available, and any given department will have a huge amount of data. What we try to do is distill out some key elements for the IPQR to give the board assurance, to indicate what the assurance committees, the governance committees are looking at in general, and things that can capture a little bit of how the whole engine's running. And the aim, certainly in clinical governance, would be that we change some of the things that appear in this, so we cycle through a variety so that we maintain interest but also demonstrate up the way to the board the breadth of monitoring and scrutiny that goes on, but also display down into the organisation some of the key bits that we want people to be aware of in terms of the bigger picture, no matter where they sit in it. Just in no particular order, I think the prostate robotic surgery, I agree in principle. It's not as simple as that, Alistair, and it may be helpful to have an offline discussion rather than to have public discussions on it.
Well, it seems to be having.
Sorry, I'm dropping.
Yeah.
So seem to be having problems today. I don't know why, but there are a number of scientific hurdles to jump over, Alistair. So rather than get into that detail in this meeting, perhaps we can offline. On your ask about can we get the data more up to date, there's always going to be a time lag in this report. I think you're asking for something that's answered elsewhere, and if you want live data, that's what people managing the system do. For assurance purposes, what comes to us is a time lag, partly so it can be made accurate, and partly so it's been through all of the stuff that's done, what I suspect you and I could be tempted to do at this level, but it's actually the role of others down below us in the organisation to do. And so we will necessarily always have a time lag in the IPQR in its data, and that is what it is. And I don't think that will change, and would be challenging to do that because you would have to shorten or bypass the processes that you're not seeing in the report, which are the local discussion, scrutiny, management and ensurement of the data before it's turned into a report that comes up the way. Even then, like any data, it won't always be 100%, but it'll be much better having been through that, which means we have to tolerate the time lag. Agree about dermatology and ENT, and indeed cataract ophthalmology is there too. I think there are some bits of work going on with that, but this report, I think that evidences the value of this report. It pulls it out, you can see it suddenly, and it's not lost in a column of numbers, and we're all looking at that, and I've already messaged people today because it stands out, and I think we have to look into that, and I think that will happen. In terms of the length of time and waiting list, there's always been waiting list management with an element of clinical input to that, and patients that are on a waiting list and their condition worsens, there are escalation routes, including through GP, but there are other ones as well, so that it's not quite, hopefully, the same as waiting for a council house, which I don't know anything about. On delayed discharges, we could and have done in the past put a finance value on it. The difficulty is that delayed discharges aren't one species. They're not all zebras or all ponies. The delayed discharges are a very varied group that's pulled into one label for information terms, but it's a diverse population of very individual circumstances. You could subset them into different things. So some of them are down to mental health legislation. That'll take 3 to 6 months to resolve, whereas others are down to something that's more related to a community hospital placement that's not available, or a nursing home that's shut and they can't go, or even adaptations to a house, which depends on the builder. So actually, it's difficult. Everyone's frozen again.
You're back on, boy. We can hear you.
Oh, we can. Oh, good. Right. Thank goodness. I was about to try and come in my phone. So I think it's of interest, but it probably isn't of value to know the value. It's probably at high level Dave Garden interest, but in terms of how we look at it and prioritize it, it probably isn't a helpful way of doing it. But we have often considered it. That's why I knew the answer to that one. On SAERs, I think we probably need to nuance and mature the data presented. This format of reports, the first time it's come out, and I just saw it shortly before we went to board. So there are a significant number of open cases. Some are historical and old and complicated. We've got some big efforts going on with backlog cases so that we can pull up. And I would simply say that 2022 has to be a year of improvement. The internal audit that you've mentioned helpfully is very much a big step in that journey and getting us. And of course, some of the delays have been about getting a variety of people together, but they have unfortunately had to prioritise with, as you know, the extreme clinical situations that we've had over the last year or two, and so that's been an element of it, but not entirely. And for some cases, they're stuck for other reasons. So what we have to do is address that backlog, and that's what I've put in the commentary at the side. Is that we now have the opportunity to start working at improvement here, where I felt that we haven't been able to move forward with previous efforts. Sorry about my connection, David, and I hope I've answered most of the questions.
Thanks, Boyd. You went beyond what I was expecting to answer, but thank you. I think that did address the questions. Bert, did you want to quickly come back in?
Yeah, it was just maybe Boyd didn't catch it because of his connectivity issues, but I suppose particularly what I'm thinking about in terms of the delays and the backlogs and to the inquiries for these reviews. Do we have a mechanism where we can identify learning at a much earlier stage, or does it have to wait until the review is complete?
Yeah, no, and so learning can happen instantly. And so the SAR process formalizes the learning and is part of the, if you like, governance. For complex cases, sometimes the learning isn't apparent until you do manage to get a whole lot of disparate folk within sometimes several different services or departments and bring them together, which is one of the challenges of SAERs, because it's getting everybody together to discuss. And sometimes in that group discussion, things will fall out that any one part or grouping within that that cohort won't identify, but when they're all together, sometimes a penny drops because they've collectively discussed when they're teams that would never normally meet or individuals that wouldn't normally discuss. So sometimes the process gives you the benefit of learning that hasn't dropped out of the immediate, but many clinical situations, the evidence is there. Something went wrong, you can see it, and things happen pretty quickly after. But we still have a responsibility to formalize it particularly when there's a serious, adverse outcome for a patient. And we almost have several processes. This is simply the most formal of those and the one that's visible to the board, but there are others.
Thank you. Thanks for those who answered the questions. Thanks for the kind feedback on the report. Thank you to Lorraine and our team who have led that piece of work. And I think it certainly, I think everybody's commented, it makes a much easier report to read and actually see the flow through of the different combination of performance data. And really, this is about showing and looking at our performance as a whole as a board. And I think the report summarises that well. It's not perfect, so we are still happy to hear feedback as we move forward. But thank you all, and I'll hand back to Boyd.
Thank you, David, and thank you, Lorraine. You've been duly commended, and I would add my voice to that. The board is asked to take moderate assurance from this report and note the format and content of report being constantly updated, and that, as David said, it's a work in process. Are we happy to take moderate assurance then from the report? Yeah, okay, in which case we can move on to the next item, which is the finance report for month 8, and invite Dave to speak to it.
Thanks, Boyd. I was quite pleased to take the finance report out of the IPQR when I saw these photographs of executives appearing in it, and thinking about that horrible picture of me on the website appearing in there. The report you've got in front of you is the high-level finance report for month 8. As David indicated for the IPQR, the finance report is also considered in detail in the finance Performance and Resources Committee. So this is a relatively high level report. It shows a monthly financial position with a year-to-date overspend on budget of £11.75 million. And that effectively means that in the budgets for the 8 months have overspent by that amount. The government have announced that they are providing support to NHS boards during the COVID pandemic this year again, to bring them back to a break-even position. So whilst we're currently projecting a £19.5 million potential overspend, our actual position is showing as break-even based on the government commitment. Included in that overspend is primarily slippage on savings of approximately £11.9 million, and the table in page 21, I think it is, gives it a summary view of the overspends at actually operational unit level. There are effectively 3 main things driving the overspend other than savings in the current year. In the Health and Social Care Partnership in Highland, the police custodial services have had a long-standing issue around locum cover, and there's about £1 million overspend in that particular area, and that's been suppressed slightly by other underspending budgets. But overall, the Health and Social Care Partnership are projecting an overspend of £564,000. The acute services, which includes both the RGHs in the Highland area and Rigmore, are projecting at month 8 a £7.3 million overspend. Driving that mainly are drug costs, which interestingly is a feature across most acute hospitals in Scotland this year, and locum expenditure are the 2 main drivers for Rigmore. And on top of that, as I mentioned, there's approximately £11 million we're projecting of underachieved savings in the current year. The month 9 position is available, and we're currently doing the reports for the Finance Committee next month. But just by way of a slightly high level update, we're expecting an improvement of around just under £3 million in the forecast in month 9, and that's primarily due to an improvement in the savings delivery. We've actually reviewed our savings estimates given the month 9 position, and we've increased them slightly by over £1 million. And there's also an improvement in the acute sector forecast as well, driven mostly by some drugs rebates that we hadn't factored into our planning process at the beginning of the year. So we will show an improvement in month 9, and that will be taken to the Finance Committee, the Finance Performance Resources Committee next month. In terms of savings, then the table on page 22, I think I'm looking at a different version than the one in the pack for the page numbers. It's page 22, shows basically again high level savings delivery split between the Highland area and Argyll and Bute as well, and shows a summarised version of that by PMO, and then also looking at the non-recurrent savings target that we have within the central area. And I say that will be updated with our recasting of numbers that we've done in month 9 and reported to Finance Committee. In terms of risk, below that table we've got highlighted areas of potential risk. Most of these are now covered really effectively by the fact that the government has given assurance around funding for the end of the year. But nonetheless, we've highlighted areas of uncertainty, and both in the current year and alluding to it next year, and particularly around adult social care. We've got the capital now, and again, a fairly high level table showing the capital spend of £72.9 million, just £73 million effectively, and we spent £26 million of that in the period to date. So we've got a big push to spend again in the last quarter of the year, and also that number is being a bit variable as well, as we've been getting a few additional items of capital allocations from national slippage over the last month or so. So again, that amount will increase as we report our month 9 position to the committee. I wasn't going to say much more on that, Chair, but I'm very happy to take any questions at this stage.
Thank you, Dave, and I invite colleagues to raise any questions. Just one thing, Dave, do we have any picture of the current element of the PMO savings to date?
I don't have the number in front of me, but we're certainly, it's considerably less than previous years. I can, if you like, when we're talking, I'll put it into chat, or if I'm allowed by Ruth, what that amount is once we're finished this item, if that's okay.
Yeah, you can come back with any information you have.
Yeah, will do.
Anne.
Thanks, Boyd. So first of all, just in terms of the position as regards the overspend on the police the forensic services, just to say that we had a good exploration of this at the Highland Health and Social Care Committee, as some people might have picked up from the minutes, and we were given some assurance that there was an expectation of being able to recruit to these posts when the business case is finalised. So that was good to hear. So that was just for your information, or to draw attention to that. So obviously, David, also very good news if we've got an improvement predicted in month 9, especially if some of that is coming from the savings programme, because that would be exceptional delivery on that front. But I just wanted to ask, obviously we are hurtling towards the year end, and we do have local council elections this year. So I wondered if the team has a plan to agree the position as regards the gap in adult social care for next year, whether we've started discussions with the council about that, and when you hope to secure agreement on that side of things. Thanks.
Thanks, Anne. Certainly, we've been in quite a number of discussions with council colleagues in recent weeks, and actually we have a meeting set up with council and government to discuss next year's position tomorrow morning. Myself and Pam are meeting with government and chief executive of the council and their finance director tomorrow, and I think very soon after that we'll have an idea of an agreement that we may have reached. I don't know if Pam wants to add anything to that.
Yeah, just that we continue to have the dialogue in the right place, and to try to get to a position of agreement and have a proposed arrangement for next year similar to this year. But we are just working through the detail of that, and would obviously require agreement from the council in that space. But as Dave says, we've got an important meeting tomorrow, and we'll follow up after that and see where we get to.
Okay. Alex.
Thanks, Boyd. Yeah, Dave, the issue on the drug overspend, for wanting a better use, was that primarily a problem with the budget being set too low? Was it inflation on the drugs? Was it a combination of both? And if it was, is that something that we will have rectified in this year's, the future year budget to come?
It's a combination of both, Alec. Certainly, we reflected on the budget setting process that we went through for the acute hospital drugs budgets, and we recognised that we probably were a little bit low in terms of our estimates for the numbers that came through. But as I said, similar to virtually every other acute hospital, there's significant pressures been seen in acute drugs. In fact, it was raised at the Directors' Finance meeting last week that seems to be a national pressure coming in. And yes, we'll have to bring that into alignment coming into next year again.
Okay. Any other questions for Dave? Okay. Are we happy then to note the contents of the report and to take moderate assurance from it? Yeah, I think so, and therefore we can move on to next two items on the agenda, which are around the culture programme and related matter of whistleblowing standards. So, Fiona, would you like to speak to the culture programme assurance report?
Yeah, thank you, Chair. So this month we are proposing moderate assurance be taken on the report from the Culture Programme. We do continue to report green for progress, and that continues a trend from November's last report. I think it is important to remember that the report is about the delivery of the Culture Programme plan and activity. It's obviously not in and of itself a report about the status of culture within NHS Highland. But obviously the delivery of the planned programme of activity is designed to enable our culture change programme, and our culture oversight group provides an ongoing forum about that and to discuss that. I just wanted to give a little bit of flavour as to why I've indicated the programme's currently tracking green, because some activity is temporarily paused. Now, in considering the progress of the programme, the Culture Programme is ready and resourced to deliver the planned activity. But in December, we took the decision to proactively pause some elements of the delivery in recognition of the substantial systems pressures that we were anticipating and had begun on our workforce, and specifically where it impacts their ability to participate in activities that we've planned. So as SRO of the programme, looking at the forecasting ahead, we took the decision that it was better to proactively pause delivery, specifically of the management development programme modules and the rollout of team conversations. Our other choice is to kind of wait and see. And actually, our teams on the ground across NHS Highland do need to prioritise the delivery of services and supporting their teams through this time. And what we didn't want to do was for people to feel conflicted about their priorities. Late cancellations also mean that you can end up with low attendances and people feeling torn about their priorities. We are now planning to restart delivery of the Leadership and Management Development Programme and proceed with the piloting of team conversations from week commencing the 28th of February, and those plans are being put in place this week. So that sort of balance of being ready to deliver but actually pausing things to protect the capacity of the organisation is why I'm proposing both a green status but taking moderate rather than substantial assurance. And the moderate assurance reflects that there are factors outside our control within the programme that influence the delivery. But as I say, the position right now compared to when I wrote the report a couple of weeks ago is significantly better, as we obviously have agreed a restart date. A couple of specific kind of updates and to reflect the fact that other activity that is less dependent on wider participation has absolutely continued to progress. So our wellbeing work stream is up and running, and our health and wellbeing group to support this has been restarted. And we've been working with colleagues to find out what they would find useful to support them with wellbeing and to utilise the funding that the Scottish Government has made available. We're also started on our detailed planning and strategy for wellbeing, which will be delivered by the end of March. We will continue the tactical activity alongside that, but as we're still in planning mode for that strategy and plan, it felt like Amber was the right status for that new work stream. Our culture metrics work stream has also been delayed by capacity and is reporting Amber, but we have now, after a number of months unsuccessfully trying to recruit, we have now got analyst resource starting next week. Despite that, we've delivered the partner listening and learning survey, which ran from the 6th of December to the 18th of January, and we had a good response to that. We had 243 responses returned. despite the system's pressures affecting all the areas we were looking at over this time. Now, we can't give a response date because actually we don't know how many people could have potentially filled it out. But basically the people we were looking to target there were anyone who works directly with NHS Highland to deliver services but aren't employed directly by us. So that could be self-employed GPs or other primary care colleagues, also colleagues working in council and third sector organisations delivering health and social care, including care at home and care home supplies. But what we were specific about is what we wanted to hear from was people who have a specific relationship with NHS Highland on a day-to-day or regular basis. So perhaps the manager of a third-party care home might have contact with us, but the sort of staff on the ground on a day-to-day basis would be managed locally. It also includes people employed by agencies or contractors, particularly in our sort of estates and facilities. Again, those who have a direct relationship with us. So we're going to be looking in the coming weeks at the results to see if there are any additional areas of focus for us to support people who work with us in that way over and above the results that we've seen in our wider population. We've obviously just had a good conversation about the staff governance elements of the IPQR report, and we've committed to agreeing a revised approach to the sort of data we report at staff governance and in the IPQR, and that will be ready for the March cycle of meetings. And we've got a staff governance development session on the 2nd of March, and we'll also be talking at that at the APF in late February. So I think the kind of key look ahead for culture is that we've got a strong focus now on planning ahead for the next year in a level of detail, but also our outline plans for 2023 and beyond. We will be starting to look at transitioning culture to be more part of our business as usual activity over those coming months, but we will continue to have a plan and continue to report on progress and have the programme board. But it's about how we make that more joined up with other elements of our people plan and make sure that the delivery is integrated into our people and culture team, which now has additional resources in place. We'll continue to work closely with the wider organisation. We'll just be organised in a slightly different way. We've got a planning day on the 1st of February with the people team, and then we'll be sharing thoughts and finalising plans across the course of February. And on that, we'll be working with the Culture Oversight Group, the Culture Work Streams, as well as our Systems Leadership Team and EDG and the Area Partnership Forum. And so we'll be bringing back the plans and approach for the years ahead to Staff Governance Committee on the 9th of March and to the March meeting of the board. So happy to pause there and hand back to the Chair.
Thank you, Fiona, for that overview. And I invite colleagues to ask any questions or make any contributions. Bert.
Thank you, Chair, and thank you, Fiona, for that update. I've just one question, and it's in relation to the leadership development programme, and we've discussed this previously. I think it's a hugely valuable and important piece of work in the whole culture agenda, and I note that you've had to pause it. You've had 72 through the first stages. Can you remind me what level of management were in attendance at that first cohort, and going forward, what will it be in the next cohorts? Thank you.
Yeah.
Fiona.
Yeah, I'm happy to pick that one up. So yeah, the 72 people that have started the programme are across 4 cohorts. So it's across all 4 levels of the programme. So level 1 is sort of first line managers, team leaders, supervisors, right up to level 4, which is our senior manager cohort. So, you know, kind of direct reports of executives and sort of that level of the organisation. So we've got a cohort for each that has kicked off. The first few sessions in the programme had been delivered. What we've done is we've just pushed out the dates to pick that back up now from February. There's been a huge amount of engagement with the process. As part of our planning session next week, we'll be starting to look at what's the rollout plan for the, those cohorts will continue through the journey because it's a modular approach for quite a period of time. What we will then be looking at is, kind of what does that next stage of delivery look like, because the sort of level 4 cohort is a relatively limited number of people in the organisation, whereas actually, kind of our level 1 and level 2 cohorts are probably significantly bigger in terms of numbers, but also probably less likely to have had formal management development in the past. So I think we will want to make sure our approach is very much tailored to support that kind of cohort. And also, I think we've learned quite a lot from the initial rollout in terms of making sure that, I think in some areas of the organisation, the messages didn't quite get through in terms of people knowing that the programme was happening quickly enough and applying for it. So we want to, again, sort of take the learning from that, because sometimes the people that are hardest to reach are the people who will be most, kind of in need or have less access in the past.
Thanks, Fiona. Can I just come back? The bit about communication of the existence of the programme is something I picked up on my last visit to Argyll and Bute, and it struck me that awareness of the programme perhaps hadn't reached there, and I wonder if any steps have been taken to try and overcome that. Thank you.
Yeah, no, it's definitely key, and I think it's a common theme through quite a lot of our communications, in that we need a range of different channels and mechanisms, and our kind of leadership structures and team structures are some of the most effective way of distilling messages and getting feedback. So that will be a big focus for us to work sort of down through systems leadership and out into the various teams to make sure people are aware of what we're doing, and finding lots of different channels to do that, because we can't just rely on kind of emails going out and hoping people see them or hope people pick them up. Especially the busier we are and the more under pressure we are, the more it's got to be discussed in kind of local forums, not just cascaded.
Yeah, thanks, Fiona. Alex.
Thanks, Bill. Thanks, Fiona. I think you've partially answered this. I completely agree about pausing things and leaving it in green, and that's fine. Did you readjust those dates to finish it? Like the March 22 for the leadership team. Has that been adjusted, or do you need to adjust them further?
So I think some of the dates have not been formally adjusted yet, and that was because we know we've got the replanning coming up at the moment. Some of the short-term dates, so for example, the wellbeing date, we've always had the end of March as our kind of plan for that to be available, and because we've got internal resource working on that, we're hoping that we should still kind of track that, and we've been trying to make sure that the things that are achievable continue out. So there's been some slight adjustments, but for some of the bigger programs, we're going to look at it holistically, because some of the same resource will work on different pieces. So we almost need to look at the big plan and the big priorities to sort of firm up the longer term dates.
So those dates may adjust. I was interested when you said about moving it into a business as usual part, which is good, and it's where we always wanted to be. Where's the feedback loop sitting? How are you going to work that? What's the success criteria going to look like? How are we going to know as a board that we are achieving success? I know that sounds an awful lot in one hit, but hopefully that's already planned for the future.
Yeah, no, absolutely. And you're right, because right at the outset, we knew that in order to sort of kickstart the programme and to get the necessary resources and focus as an organisation, we had to sort of set this up very much as a programme. But actually, this culture is what we all do every day as leaders, as managers, as colleagues, interacting with one another in the organisation. And the longer we maintain a very separate programme on its own, the more almost culture is a little bit, something that I do in my job, and I'll it's up to me and Pam and some others to get that sorted out. So I think, as you see, the move is the right one. I'm very clear, and we'll see it across the way we're managing all of our strategic priorities that we've discussed today, that actually, despite that being part of some of my team and other people's day jobs to support the delivery, we'll still very much have that programme board structure. We'll have that dashboard reporting will be tracking progress on the outcomes and the delivery, because that's got to be the rigour and the robustness that sits behind it. For culture, for example, whether or not we continue long term to have culture as a separate programme board, or whether our culture programme board and our workforce programme board, kind of ultimately jointly report on some of these things, that will be seen. I think the piece that you've picked up, which is really important, is that as well as finding a kind of business as usual home and plan for culture, we mustn't lose the connection and the involvement of the organisation in doing that. And so we will continue to have a wide approach to who's involved in the different, kind of pieces of work in the oversight. We're also very keen, again, one of the things that hasn't pushed forward just in the last month or so is the setting up of the listening and learning panel, but that is very much a priority for us, so that we've got different routes into the organisation. And then we'll continue to look at those culture metrics, and I say we've got things like the onboarding and exit surveys that are going to be deployed in the next 3 months or so. So we've got to get more and more sources of both interaction and contribution, but also those measures that we've been seeking for some time. And I think we're starting to head towards now having a much better range of metrics to measure our progress.
Okay, Pam.
Yeah, just to add, I mean, critical to all of this and really embedding it and getting people to feel really confident and comfortable in their leadership and management roles, I'm going to take that piece particularly, is PDP and appraisal. And so, in some ways, if we had that in the right place, we would know who needs to go on these courses, who would benefit from them. So I think we need to, in tandem with this, we absolutely need to go into next year with a huge focus on those conversations, because if we want people to understand the direction of travel or to be able to comment on that, you have to have the discussion. If we want to understand better where people are confident and where they're not, you have to have the discussion and formulate that. So I think that's going to be an important indicator for us to be much more focused on, because the other aspect to, we can put on as many courses as you like and programs as you like. If you go back into the workplace and the culture and custom and practice is different to the culture and custom and practice that we're trying to create, people will get pulled back into that. So we really need to think about this in developmental terms and organisational terms, and every single one of us need to value how we set up objectives, appraisal and PDP in this, if we really want it to look and feel different, as well as all the other activities that are going on. So I feel that we are in a position where we have to major on that.
Thanks, Pam. Sarah, did you want to come in and notice your hand up at one point?
Thanks, Chair. I was too slow getting my hand up. I was trying to come in straight after Fiona just to talk a little bit more about how we had RAG status done that process in the Staff Governance Committee. So a little bit of a moot point, but just to kind of back Fiona up, we did at Staff Governance Committee go backwards and forwards on it quite a lot. So just to give this board a bit of assurance there that we had gone through that process. And I guess ultimately, as Fiona has explained, we landed on the green because I suppose thinking about what the alternative would be and what the purpose in ragging it anything else would be, we realised that that was the right place to put it, and that actually doing anything different would be counterproductive to the kind of supportive culture that we're trying to develop. So it was, but as I said, I was too slow. That would have made much more sense if I'd come in straight after Fiona, but there we go, just to back her up on that.
Thank you, Sarah. Any further questions for Fiona? I think the overall picture is one of limited progress from the last meeting, but that progress has been made nevertheless, despite that last meeting being November. the festive season intervening, and also, of course, the pressures arising from the Omicron variant. So we would look to see substantial progress in the next couple of months, and Fiona has highlighted some of the aspects of culture of the culture programme on which we would anticipate some rapid progress emerging over the next couple of months. Are we happy to take moderate assurance from the report? Okay, thank you. Then we can move on to the final item for this morning, or what was this morning, the Whistleblowing Standards Assurance Report, and Fiona again.
Thank you, Chair. I'm always pleased when I'm the only person between everyone and their lunch, especially when it's delayed. So I'll try and be as concise as possible. And as you say, we're recommending again moderate assurance be taken from this report. Although moderate isn't normally a word I'm used to using in context with things I'm presenting, but I'll just talk you through what you've got in your pack. You've got the second quarterly whistleblowing report, and that covers the period 1st of July to the 30th of September. There's obviously also the covering SBAR, and we've also included the recently completed audit of our whistleblowing standards implementation, which went to Audit Committee in December. Now, we have a slight challenge with the quarterly reports because obviously board is bi-monthly and the reports are quarterly. So we did get a little bit out of sync with this, but you'll see within the report, I've put a proposed schedule of when these will now be coming over the course of the next year to the board. And so quarter 3 will be at the March meeting and quarter 4 will be at the May meeting. I say we're proposing a moderate level of assurance for this report, I think reflecting our progress in implementation, as well as activity in promoting the standards and the relatively positive audit report. But I think also taking into account that we do have some actions to conclude by the end of March related to the audit. And once these are complete, I'd be hoping that we can provide a substantial level of assurance going forward. In terms of the report itself, we've retained the core elements from the background and context in the quarter 1 report. It's a delicate balance, but we want to make sure that given we only see these reports quarterly, that you've got enough of the information about how the process works and what the roles and responsibilities are to support us in our monitoring and oversight role of the standards, but that we're not repeating absolutely everything. So there is the ability to go back to the quarter 1 report if there is any more detailed information. Feedback about the report style, format and content, which continues to evolve, is always welcomed, kind of at any point in time. We have had only 3 whistleblowing cases reported to date, up to the end of quarter 2. One of these was closed in this period and some learning implemented, but the case wasn't upheld. We have 1 ongoing case and 1 new case in this quarter, and both of these cases, because of the nature of them, are being led by Fiona, our Chief Officer in Argyll and Bute, and myself. They involve quite complex and wide-ranging aspects of remote and rural service design and delivery. Now, the approach we're taking with these allows us to sort of address issues as we investigate and discuss them. So it does take more time to conclude than a fairly kind of straightforward investigation. But we're ensuring a very thorough process is followed, and we've got all the necessary stakeholder engagement into the process. And despite those durations of investigations being longer than in some cases, we do meet the requirements of the standards in terms of updating complainants every 20 days. The low number of cases does mean that it's quite challenging so far to report on trends and lessons learned to any great degree, but we are trying to sort of, kind of provide that information, and as we get more data, we will, kind of update the reports. What we have done in the reports, you'll see, is that we've always taken the approach to be able to report on not just the concerns that we agree are whistleblowing and take forward, but to report on concerns raised under whistleblowing that we then judge not to be meeting the whistleblowing standards. The cases to date have all related to Argyll and Bute in terms of the ones that have taken forward, but actually I think what you'll see from the cases that have been reported and not found to be whistleblowing, it's more broad across the board area. We have included the detailed audit report with the papers, and in the report there's an update on progress with implementing the audit actions. At the time of writing the report, 3 had been completed. Actually, the 4th action, which was due on the 31st of January around contact details, was also completed last week, and we are on track to complete the remaining 2 actions by March 2022. I think it's also worth highlighting that Bert, as our whistleblowing champion and non-exec, has continued to play a pivotal role for us, both in the implementation and oversight of the standards, but also in extensive ongoing visits and engagement across the board area. And that's being available to colleagues to understand their experience, as well as promoting awareness of the standards. And despite kind of lockdowns intervening, Bert's visited Oban, Mull, Dunoon and Fort William last November, Loch Gilphead, Campbelltown, Rothesay and Helensburgh in July last year, and up in Caithness, Sutherland and Inverness next week. So this is a hugely valuable part, and it's probably a slightly different way to some other boards have implemented the model, but it's been really beneficial for us because actually kind of the kind of going out and seeing particularly our more remote and rural communities and people feeling that they can speak to someone slightly independent and impartial is giving us lots of helpful information about what we need to do. As a result of the ongoing engagement that we've had both formally and informally with the INWO, the National Whistleblowing Officer, that's been really helpful, and I think they've sort of come to us on a number of things nationally. I've actually been asked to be the independent panel member for the appointment of 2 further whistleblowing champions in other boards. And I think we've also engaged with the INWO where somebody challenged one of our decisions around something not being whistleblowing, and the outcome of that review by the INWO was that they did agree with our assessment of the case. And I think that feedback and ongoing dialogue is really helpful to us because these standards are new. We're not using them that often because of the number of complaints. So getting a little bit of engagement and feedback and confidence in our processes, I think, has been really helpful for us. So I'll pause there and hand back to the chair for any questions.
Thank you, Fiona, and invite contributions, questions for Fiona. Bert.
Yeah, thank you, Chair. Thank you, Fiona. I thought I might just add a few things which hopefully will be helpful from my perspective as the whistleblowing champion. Fiona has covered most things, but I guess from an assurance perspective, just to say to the board that the report contains what the standards require us to report on. My involvement with Fiona and others assures me that processes are being followed. I particularly welcomed the internal audit. I think that's always useful to have, and I think the report was relatively positive, and what has been identified, as Fiona has said, will be fulfilled in the next month or two. The independent report did say that there was little mention of emerging trends, but I think there's a very reasonable explanation for this, and that is the low numbers really don't allow us to make an assessment of trends. What I would say is that when concerns have been raised and issues have been identified, then steps have been taken to implement remedial action. In terms of where we are with the standards, then I'm comfortable that within the NHS itself, the processes are there. I think there's still work to be done out with that, and I suppose I'm talking about external contractors. This is, I guess, is no different from other board areas, and it's part of a journey. But work is underway. I know, for example, that in recent times there's been discussion with UHI about the involvement of students and what they need to know and about the processes. So that is all underway. This report, of course, will have to go to the Argyll and Bute IJB and to the Highland Health and Social Care Partnership. The numbers of concerns raised are low, 12 up until the end of the second quarter, which is that's a 6 months period. So 12 concerns raised, 3 of which have been assessed as being whistleblowing. What does that tell us? I don't know. And I think it would be unwise to make any judgment or assessment of what these figures are telling us. What I do believe, and what I continue to say, is that communication and awareness raising is absolutely fundamental. And I've had discussions just recently with Ruth Fry about trying to continue that. I'll be taking part in an Ask Me Anything session coming up shortly. I can't remember when it is. And of course, next week, I'm doing another 3-day visit to North Highland. And I think that can also be viewed as part of this communication and awareness raising strategy, as well as allowing me the opportunity to gauge a sense of the temperature within the organisation in these areas. So I'll pause there, and hopefully that's been useful for board members. Thank you.
Thanks, Bert. Can I ask you, Bert, from your participation in the national networks, how do our stats compare, if you have that information, with other areas?
I don't have the stats nationally, Boyd. I'm sorry.
Okay. Philip.
Yeah, thanks, Boyd. I was just reading through the internal audit report, and there was just a bit that caught my eye. Whilst we're dealing with very low numbers, I appreciate that makes things difficult, but there is a bit in the executive summary in the conclusion that found that there was inconsistencies in the approach taken, and I just wondered if that's something that Fiona recognises, and if it is, are we doing anything to address these findings?
Did you get that, Fiona?
Yeah, yeah, happy to pick that up. So, and for context, I suppose the audit was actually conducted sort of around June, July time. So right at the start of the process, and at that point we'd only had 2 of the whistleblowing concerns. It was really helpful to us because I think what that report it refers to is the fact that the case that has been closed, which was around a health and safety issue, was a slightly unusual case, and but for various reasons, some of the standards that we had around kind of regular updates around it hadn't all been captured. There was also a bit of a delay in us sort of concluding that case. So it was quite specific to 2 cases being handled slightly differently. But what it has done is allowed us with further cases and concerns that have come in to be much more kind of focused on making sure that we do follow the process, we keep people updated, and that we're kind of being consistent with that. One of the benefits that we have in terms of the relatively low number of concerns that come in is that as the board INWO liaison officer, I'm involved in every single case or potential case, along with the whistleblowing, kind of support line from the Guardian service, and it allows us to have a level of consistency. Obviously, I engage with all the relevant SMEs and chief officers and professional leads in each specific concern, but I think it's allowed us to have a level of consistency and that's quite important, I suppose, in evaluating concerns. And I think that's obviously, if we were to see huge increases in numbers of concerns, we might need to rethink the approach, but we've gone for a very senior level of involvement, partly because of the subject matter, because quite often the things that are coming through are quite kind of strategic or long-standing, or, you know, kind of service delivery related issues. So I think that we're definitely working on that. The final piece of that jigsaw is that the approach that we've set out in terms of how we do handle concerns and the process we take to make decisions and feed that back, that one of the final actions of the audit is for that to be captured in a process that then, alongside all the information that's available around the whistleblowing standards, we can promote that. And so there's a very clear sort of transparent you know, kind of setting out of who makes what decisions, where do they go to, and what standards we apply to, that's specific to Highland and our approach, not just to the national information.
Thank you, Fiona. Any further contributions? If not, are we happy to accept the moderate assurance that's offered in the report? We are. Okay, thanks. And I think it's lunchtime now. Could we come back at 2:05, a 20-minute break? Would that be appropriate? See if we can catch up a bit. 2:05. Thank you.